All right, welcome to this explainer. If you're prepping for your finals, this is your high-yield revision guide on intravenous immunoglobulin, or IVIG, specifically for when you're dealing with a critically ill patient. We're going to give you the essential, must-know facts, plain and simple.
So, here's our game plan. We'll kick things off with the basics. What exactly is IVIG? Then, we're going to unravel how it actually works. After that, it's straight into the key ICU indications, the stuff you're definitely going to see in your exams. Then we'll cover the really important risks and wrap it all up with a few controversies and the big exam takeaways.
Okay, first things first. Before we even think about the why and when, we have to get a really solid grip on what we're actually prescribing when we order up a bag of IVIG.
As most basic, you can think of IVIG as a borrowed immune system in a bag. It's a blood product that's been around for a while, first used way back in 1952 for people with antibody deficiencies, and it's made by pooling the plasma from thousands, and I mean thousands, of healthy donors.
And get a load of this number. The scale is just mind-boggling. A single batch of IVIG can have plasma from up to 15,000 different people. Now, that's not by accident. That massive pool is exactly what gives each bag such an incredible diversity of antibodies ready to take on a huge range of bugs and antigens.
And this here is the key tool in the box, the antibody itself. You can see it's got that classic Y shape. Now, the two arms at the top, that's the Fab region. Think of those as the hands that are designed to grab onto specific targets. The stem at the bottom is the FC region, and that acts like a flag to call in the rest of the immune system for backup.
Okay, so we have this cocktail of antibodies. How does it actually do its job inside a patient? Well, it's way more complicated than just topping up what's missing. Its effects are incredibly broad.
Honestly, we're still working out all the details, but we've got a pretty good idea of the main ways it works. For one, it can directly neutralize toxins and pathogens. It can also opsonize, which is a fancy way of saying it tags invaders for destruction. It can calm down the inflammatory complement system, and, this is a big one, it can saturate all of the FC receptors on our own immune cells, which basically tells an overactive autoimmune response to just calm down. It even messes with our own B cells and T cells. It's pretty amazing stuff.
Now, your body makes 5 different classes of immunoglobulins. You can see them all here. You've got IgA for your mucosal surfaces, IgE for allergies, IgM is the first responder, but when you look at what's actually in a bag of IVIG, one of these is the absolute superstar. And there it is. This is the crucial point. IVIG is overwhelmingly made of immunoglobulin G, IgG. We're talking about 80% of the whole product. And that's huge, because IgG is the workhorse of your immune system. It's also the only one that can cross the placenta, which just goes to show how fundamental it is to our immunity.
Okay, let's get to the sharp end. For your exams, you need to know exactly when to think about using IVIG in the ICU. Let's run through the big ones, the high-yield scenarios that you're almost guaranteed to be asked about. Right, Guillain-Barré syndrome, GBS. This is a classic exam topic. So the big trials showed that both IVIG and plasma exchange are pretty much equally good at helping patients recover. But, and this is the key point for your answer, IVIG has some major practical advantages. It's just so much easier to give. You don't need a special machine or staff, and because of that, patients are way more likely to actually finish the whole course of treatment.
Another really key one is VIT, or vaccine-induced thrombotic thrombocytopenia. It's rare, but it's serious, and you need to know how to diagnose it. The path is crystal clear. You need to tick all 5 of these boxes. The timing has to be right post-vaccine, there has to be a clot, platelets have to be low, the PF4 antibody test has to be positive, and the D-dimer has to be through the roof.
Now, we can't talk about the benefits without a serious look at the risks. Giving IVIG is a big deal. It's a powerful therapy from thousands of people, and it comes with significant risks that you absolutely have to know about before you even think about writing that prescription. Adverse effects are pretty common. You'll see things like fever, chills, sort of flu-like symptoms. But you've got to be on high alert for the less common but much more serious stuff. Things like anaphylaxis, heart attacks, kidney failure, and clots. As you can see, it can affect pretty much every system in the body. So if an examiner asks you for the main risks, these are the big 3 you have to have locked in your brain. Number 1, clots, both venous and arterial. Number 2, aseptic meningitis. That's inflammation of the brain lining that isn't caused by an infection. And number 3, acute kidney injury. These are the life-threatening complications we're trying to dodge. All right, let's wrap this up.
We'll touch on some important controversies, and then we'll boil it all down to the absolute key takeaways you can carry with you, not just into the exam hall, but into your clinical practice too. So, this is a hugely important question. When should we just not use IVIG? Knowing when to hold back is just as critical as knowing when to prescribe, especially with a resource this precious and risky.
Now, this is crucial to know. Even though you might see it used historically for some of these conditions, current UK guidelines do not recommend IVIG for necrotizing fasciitis, SJS, or TEN. Why? Simply put, the high-quality evidence just isn't there to back it up. And it's also not recommended for just general septic shock when you don't know what bug you're fighting.
Okay, time to summarize. Here are your 5 final exam takeaways. 1. IVIG comes from a massive pool of up to 15,000 donors. 2. Its mechanism is super complex. It's an immunomodulator. 3. Know your key ICU indications cold, GBS, myasthenic crisis, and VITT. 4. Watch out for the big 3 risks: clots, kidney injury, and aseptic meningitis. And finally, number 5. Prescribe it responsibly. It's expensive, it's scarce, and it's risky, so always follow your guidelines.
And that really leaves us with this one final thought. IVIG is an incredible, powerful tool, but it's expensive, it's in short supply, and it can cause real harm. That puts a huge responsibility on us. So the question we have to ask ourselves every single time is this: for this patient right in front of me, am I absolutely certain that the benefit is going to outweigh the risk? This explainer was based on the article The Use of Intravenous Immunoglobulin in Intensive Care by Sylvester, Labaz, and Bowles, which was published in BJ Education in 2024.